Sounds great.
Good afternoon and welcome to the Getting the Vaccine to the Communities That Need It Most. Before we begin, I would like to highlight the main features of the Zoom webinar interface. At the bottom of your screen is a Zoom menu bar. Here you will find the Q&A box. We encourage you to use this feature to submit questions at any point during the meeting. We will leave time for Q&A after the presentations. At the bottom of your menu bar, you will also find a chat box. Please use the chat box to report any technical issues you may be experiencing. We will respond to those concerns as they come in. Additionally, live captioning is available during today's broadcast. Simply click the CC icon from your bottom menu bar to use this feature. Finally, remember that today's meeting is being recorded. With those announcements made, I will now turn it over to Lauren.
Thank you, Jennifer. Thank you, everyone, for joining us today. My name is Lauren Pongin, and I use she and her pronouns. I'm the National Director of the Diverse Elders Coalition. Founded in 2010, the Diverse Elders Coalition advocates for policies and programs that improve aging in our community as racially and ethnically diverse people, American Indians and Alaska Natives, and lesbian, gay, bisexual, and/or transgender people. We have 6 member organizations and representatives from several are on today's call. We have the National Asian Pacific Center on Aging, or NAPCA, the National Caucus and Center on Black Aging, NCBA, the National Hispanic Council on Aging, the National Indian Council on Aging, SAGE, and the Southeast Asia Resource Action Center. On today's webinar, we'll feature multiple speakers with different backgrounds to talk about some of the health inequities of our diverse communities that were worsened during the pandemic. These inequities have persisted today and continue to affect our communities, even as we organize to get our communities fully vaccinated. Some of the inequities include lack of vaccine locations in high poverty and under-resourced communities, particularly in our rural communities, lack of vaccine information, including translated materials, language barriers, technological barriers for registrations, and more recently, vaccine access for our aging loved ones that are homebound. Today, we'll be exploring these topics and offering some resources to mitigate these issues. Our speakers will be talking specifically about vaccine access in urban and rural diverse settings, how language affects vaccine access, and barriers to vaccines in diverse communities. At the end of the webinar, as Jennifer mentioned, we'll have a Q&A section where the audience will be able to ask our panelists questions. And we'll also be featuring some polling questions so that we can hear from all of you who are attending And we really value your participation in these polls to understand better what your interests are in learning about vaccine issues and to understand how vaccine rollout and is going in your area. So some of the, so I'm going to turn it actually back over to Jennifer to start with launching one of our polls.
Thank you. Our first poll is, what brought you to this webinar? We have choices. I'm a caregiver who wants to learn more about vaccine access. I'm an older adult who wants to learn more about vaccine access. I'm here to learn more about resources for vaccine access for my community. I just want to learn more about vaccine access, and I'm looking to learn more about diverse communities and vaccines. So we're just going to leave the poll open for about 5 more seconds to let more of you go ahead and vote. And as you can see, that a lot of you are here to learn more about the resources for the vaccines in our community.
Thank you, Jennifer. So it's my pleasure today to introduce our first speaker, who is Phyllis Arthur. She's the Vice President of the Infectious Disease and Emerging Science at the BioTechnology Innovations Organization, or BIO. BIO is one of the sponsors of this webinar. In this role, she works with pharmaceutical companies who develop new vaccines, infectious disease treatments, and antibiotics. So I wanted to give a warm welcome to Phyllis and thank you for helping us sponsor this webinar, and we'd love to hear from you.
Wonderful. Well, thank you, Lauren, and thanks so much to Jennifer and everyone, all the great organizations that have organized this event today. We're very proud at BIO to be working with many of the organizations that represent communities, ethnic groups, multicultural organizations that are reaching very much into our important communities to get them access to vaccine and to educate them on the importance of getting vaccinated and protecting themselves and their loved ones moving forward. Working together as we have with the community-based organizations and faith-based organizations, I think we can really exit this pandemic, and more importantly, learn from it what we need to do between now and, unfortunately, probably the next pandemic we'll face or the next global crisis that we'll face, and be more resilient in the future. I represent the companies that have been making novel vaccines, diagnostics, and therapeutics for COVID-19, and make many different medicines as well. And I just wanted to call out 2 different things for the group in terms of how we hope that our industry can work collaboratively with the community-based organizations to bring these products to everyone who needs them and wants them. So in September of 2020, the industry leaders, CEOs of many of the different companies that make the vaccines you're getting now or that you will see in the coming months, joined together to make a pledge to really hold to the high scientific rigor and the transparency and the very important diversity in their clinical approach to making these vaccines. The companies pledged in a public announcement in the New York Times to always make safety and the well-being of patients the top priority in the way they approach their research and also their manufacturing, so that you have lots of data around safety as much as we could have in the pandemic. You'd have a commitment to follow these vaccines once they were launched and make sure we were always gathering and communicating new data. And you'd have a commitment to high quality manufacturing standards around the world, so everyone was getting vaccines that were well made. Together, these 9 companies that made this pledge actually have collectively developed more than 70 novel vaccines over the course of their time. These are companies that are making the vaccines that you and your children get every day around the world. And I want to just call attention particularly to the way that companies tried to work closely with community organizations and government officials to ensure that they had very robust involvement of individuals of different races, ethnic groups, ages, very important to have that breadth of ages, and underlying conditions. So there were people in the trials who had diabetes, who had different heart disease, who had different pulmonary or issues, respiratory issues. So we could make sure with the 30,000 people studied per vaccine that we could bring to the American people robust data to make sure everyone felt comfortable with that taking the vaccine when they could. And so I wanted to reinforce that commitment industry has made, and then discuss how we at Bio, in the next slide, have been working to broaden the educational activities that bring information to people in simple language. So at Bio, we launched in last December a website called covidvaccinefacts.org. The site is actually set up like Bing. It's actually a question and answer site. So you can type in a question like, how will I know if the vaccines are safe and effective? Or could I be allergic to a vaccine? And there are 38 questions to date, and we add more questions as we learn more about each of the vaccines. As we go from having 2 vaccines to 3 vaccines, we change the questions to include information about not just Pfizer and Moderna, but J&J's vaccines. As new ones are approved, we'll add it. We have 2 video animations, very simple. One of them explains how we could go so quickly in developing the vaccines. That's one of those key questions many people have. And one just talks about the side effects we'll see and how people can make sure that they log the side effects and know what to expect. So we really would like to encourage people to leverage the site, either if you're in a community-based organization, linking to it and sharing it. The questions are answered in a very straightforward way. They're well sourced, and we try to keep them as simple as possible. The whole site can be, you can click on a button and the whole site is available in Spanish as well as English. And our plan is to continue to add more and more questions in English and Spanish as we move forward. We're very happy that this is getting lots of use, and we'd love to have people view it as a resource for them to use as well. We're looking forward to the conversation today and to continuing to work with all the great groups that are included in this webinar. Thank you very much, Jennifer.
Thank you so much, Phyllis. We really appreciate you being here and being a sponsor today. I don't see any questions right now. So there is one question, is this information available in Spanish and other languages?
So right now we've just done Spanish, and we've actually had it translated. We have a firm that just translates all of our questions for us. So we're using someone to make sure our Spanish is accurate and appropriate. So right now it's only in English and Spanish. I think if we can continue the site, we would certainly like to add another language, but we have these 2 at the moment. Would love to partner with someone if they'd like to help us translate into other languages that may be important.
Get some offers through the chat. Let's see.
Well, I'll try to copy the chat as well. We're always looking for new partners in the education space on the COVID vaccines.
Fantastic. Well, thank you so much, Phyllis, again. We are going to go ahead and we have another poll question that we're going to ask, and it is, are you eligible to receive the COVID-19 vaccine? Have you gotten the vaccine? We've got, yes, I am eligible and have gotten it. Yes, I'm eligible and plan on. Yes, I'm eligible but haven't. No, I'm not eligible, but I plan to get it. No, I'm not eligible and I don't plan to get it. And I don't think I will become eligible to get the vaccine. And we'll leave it open just for a few seconds because we do have another poll after this. So just a couple more seconds to let more of you go ahead and vote. So we'll go ahead and end that poll, and we'll share is that a lot of you are eligible and have gotten it. That's fantastic, but we still have some work to do in the other areas. So I'm going to go ahead and stop share, and then we are going to ask you another poll question about how much do you agree with the following statement? I have all of the information I need to know about how the vaccine works, what to expect, and its effects. We've got, I completely agree, I somewhat agree, I'm neutral, I somewhat disagree, and I completely disagree. And again, we'll leave it open for a few seconds so that we can get as many of your responses as possible. We'll just leave it open for just a few more seconds. So we'll go ahead and end the polling and we'll share. And a lot of you are, I somewhat agree, but we also have, you know, I completely agree. So that's great. Thank you so much for participating in that. And then I'll go ahead and turn it over to Lauren again.
Thank you, Jennifer. It's my pleasure now to introduce Dr. Yanira Cruz. Dr. Cruz is the president and CEO of the National Hispanic Council on Aging, one of the members of the Diverse Elders Coalition. Dr. Cruz is one of the nation's foremost advocates and spokespersons for diverse older adults and is nationally recognized for her commitment and leadership on behalf of diverse older adults. Welcome, Dr. Cruz.
Thank you, Lauren. Thank you. It's great to be here. Buenas tardes a todos. I think having this conversation on getting the vaccine to communities that need it most is so important today. So thank you. We are officially 1 year into the COVID-19 pandemic, and hundreds of thousands of lives have been lost in the United States. Worldwide, we have lost nearly 3 million people. The coronavirus, we think, is one of the greatest threats of our time to our health and the global economy. It really spares no one. Today, the US Food and Drug Administration has approved 3 vaccines for emergency use: Pfizer, Moderna, and Johnson & Johnson. And these vaccines are important tools to help stop the spread of the virus and in an effort to end the pandemic, and that's wonderful news. And as we roll out the COVID-19 vaccine, we have to ask ourselves if we have an equitable response to the current pandemic. We know that many communities are experiencing challenges accessing the vaccine. It's clear that supply is a problem. And a bigger problem is that some older adults in the communities hardest hit by the pandemic are not able to access the vaccine due to other barriers. For example, to register for the vaccine in Washington, D.C., in Maryland, and in other states, a person needs to access an online portal when registration becomes available. The reality is that most of our older adults do not have access to a computer or a laptop or a smartphone or even access to internet. And those that do are actually not technologically savvy. Others cannot complete the registration since it's available only in English, which is a huge barrier for those who only speak, read, and write in a different language. Many online portals have been reported to be difficult to navigate due to the heavy traffic of people trying to get an appointment via this platform. And so today I would like to share the story of Victoria, who is a 72-year-old and a resident of the District of Columbia. Victoria didn't know how to get enrolled to be vaccinated since she lives by herself and is trying to stay as safe and as healthy as possible at home. The information did not get to her, especially online, since she does not have a computer or the knowledge to go through the DC online portal. Then there's also Elia. Elia is a 92-year-old who lives in our housing facility in Washington, D.C. Elia was eager to get her vaccine after receiving a call from her medical doctor, but the lack of transportation was keeping her from getting her vaccine. Now, both Victoria and Elia have now been vaccinated, thanks to a group of staff and volunteers at the National Hispanic Council on Aging that helped the older adults enroll for the vaccine and provided transportation to the vaccine location. And stories like Victoria's and Elia's are unfortunately far too common, as older adults across the country struggle to get vaccinated. And as we predicted back in December, the vaccine distribution process is filled with barriers to accessing the vaccine, from technology and transportation to logistics and language. And so preventing inequities in the distribution of COVID-19 vaccines is important to ease the disproportionate impact of the virus for our people and to prevent exacerbation of racial health inequities. Current plans and frameworks are falling short. Elected officials and public health departments need to engage community-based organizations to ensure they can successfully vaccinate those most at risk. A recent report by the Kaiser Family Foundation shows a consistent pattern of Black and Hispanic people and other communities of color receiving smaller shares of vaccination compared to both their shares of COVID-19 cases, deaths, and the share of the total population. And so these must be rectified. So I have some recommendations. First, we urge local governments to work with community leaders to execute a plan to get the people from their community, particularly those at risk, older adults, and persons with disabilities, to have access to the vaccine. Second, establish multilingual helplines where people can call to get information, get help with enrollment for the vaccine, and also get transportation to the vaccine location for both shots. Third, deliver bilingual automatic voice messages in smartphones or landline phones on how to get the COVID-19 vaccine by providing a number to call if people cannot access the internet to get an appointment for the vaccine. Fourth, allocate more funding for outreach and education to educate, inform, activate vulnerable communities to get vaccinated. And while most states have COVID-19 trackers on public websites, few are actually reporting disaggregated data showing which populations have received the vaccine. Making transparent these data about who's getting the vaccine allows for greater accountability to that goal. So following these recommendations creates a foundation for a more equitable response to a pandemic that has attacked the country and its older adults in the most inequitable of ways. Though we recognize that these recommendations don't solve the problem of vaccine scarcity, we do know that they help ensure people who have been most impacted, like Victoria, like Elia, and more older adults can have access to a vaccine that may save their lives. Muchas gracias.
Thank you, Dr. Cruz. Thank you for sharing that perspective. And it's always really important to hear community stories so we can understand the real barriers that communities are facing. And I loved hearing your calls to action around language access and making really common sense interventions, such as having hotlines and bilingual resources for folks so that especially older adults can overcome barriers or technological barriers to vaccines. Speaking more around this topic is Denny Chan, who I'm very excited to welcome. Denny serves as Justice and Aging's inaugural directing attorney for equity advocacy and is responsible for developing and leading Justice and Aging's strategic initiative on advancing equity with a primary focus on racial equity for older adults of color. He's based in Los Angeles, California, and serves on California's Community Vaccine Advisory Committee, where he advocates with others for vaccine equity. Denny's a member of the California Bar and is a graduate of the University of California, Irvine School of Law. Welcome, Denny.
Great, thank you, Lauren. Good morning / good afternoon, depending on which coast you're in. Thank you so much to Lauren and Ocean and everyone else who's organized and put together today's webinar. I'm really excited that Justice and Aging is both speaking but also co-sponsoring the webinar today. You will find that as I go through my presentation with a specific eye toward language access, that a lot of my comments echo what Dr. Cruz's comments were from before. And we also have some specific recommendations that are very much in line with hers as well. So next slide. In case you haven't heard of us before, Justice and Aging, we're a national legal advocacy organization, and we use the power of law to fight senior poverty. We do that in a couple of main programmatic areas, including healthcare, economic security, access to the courts, elder justice, and in housing. And since 1972, when we were first founded, We have focused our advocacy efforts on those populations of older adults, those communities of older adults that have historically lacked legal protection, such as older women, older adults of color, LGBTQ older adults, and older adults with limited English proficiency. And just last week, in case you didn't know, we did launch our new strategic initiative to advance equity with a specific focus on race equity for older adults of color. So this is a very important and very timely topic in light of our strategic initiative launch last week. Next slide. We have had for many years now an internal commitment to diversity, equity, and inclusion that has allowed us to advance our strategic initiative around centering equity for older adults. So that involves, in terms of fighting senior poverty, we have to recognize inherently the ways in which senior poverty is racialized and poverty in this country overall is racialized. Those two cannot be disconnected. And in particular, that involves acknowledging and addressing the enduring negative effects of racism and differential treatment by promoting access and equity in all of our programmatic areas. And internally, we have to start at home. It means that we have to recruit, support, and retain a diverse staff and board among many different types of diversity. And for more information about justice and aging and our diversity, equity, and inclusion work, you can feel free to visit our website, justiceandaging.org. Next slide. All right, so I want to first start off by telling the story of COVID. And this is a story that has gotten some attention, but I think it's really worth highlighting the ways in which race and age have worked together to make older adults of color more vulnerable, more at risk, and more likely to have adverse outcomes from COVID-19. If there are two lessons I want you to take away from my 10-minute presentation here, it's that one, COVID-19 has taken a very, very bright flashlight and exposed all the different ways in which medical racism and other types of discrimination work to keep older adults of color disadvantaged. And also that everything about COVID-19 has been, we are building the plane while we're flying it. And so that you will see very much as I start talking about the vaccine rollout. But starting in June of 2020, CMS, the Centers for Medicare and Medicaid Services, began releasing data about the impact of COVID-19 on Medicare enrollees, who by definition are older adults or people with disabilities. And it also included specific reporting for people who were dually eligible, that is low-income older adults, people who are eligible for Medicare and Medicaid. And what you see in the data is that dual eligibles are over 2.5 times more likely to get COVID-19 compared to Medicare-only enrollees. So there you see sort of at least implicitly working issues of class, because dual eligibles are by definition low income. And dual eligibles are almost 3 times likely to be hospitalized from COVID-19. In addition, the CMS data also included reporting by different racial groups of Medicare enrollees. And what you see across the board is that many Medicare enrollees of color experience higher rates of COVID-19 hospitalization than white Medicare enrollees. And if we go to the next slide, you can start to see some of that play out graphically. So what we know from the Medicare data, and this is data as of through the end of last year, so it caught half of that winter peak, but didn't include, for example, January and February data. What you see is that even when you control for class, so if you look just at Medicare enrollees who are not dually eligible, or if you look at dual eligible enrollees and not compare them to Medicare enrollees at large, is that there are still differences in how communities are experiencing the pandemic. And more specifically, American Indian, Black, and Hispanic dual eligibles are more likely to be hospitalized from COVID-19 compared to white dual eligibles. And that trend is true too for Medicare-only enrollees. And so what this graph shows you is that among certain communities of color, American Indian, Black, and Hispanic older adults and people with disabilities on Medicare are more likely to be hospitalized and have, and you can imagine in December, we were not in a place where we had tons of hospital beds, depending on which community you were in. So this is really driving home the point that the virus has taken that really bright flashlight and exposed and exacerbated the existing disparities that existed well before COVID-19 reached our shores. Next slide. So that's the story of COVID-19 in terms of hospitalizations and infections. What about, language access? When we think about language access, there are a couple of key legal protections that we have to first identify. And I'm not going to go through an elaborate list here, but this is at least what I want to highlight from a high level. First is Title VI of the 1964 Civil Rights Act. That prohibits actually a discrimination on the basis of race and ethnicity and color. And the Supreme Court has interpreted that in a case from 4 decades ago to include national origin. And national origin includes language. So you cannot be discriminated against on the basis of the language that you speak, especially if that language is not English. That applies to all federal programs that receive federal financial assistance. Fast forward, in the 1990s, President Clinton issued Executive Order 13166, which required federal agencies to have plans put into place on how they would best serve limited English proficient individuals. And Section 1557 of the Affordable Care Act, fast forward even more, that was passed under President Obama, has a non-discrimination provision that includes language access as a part of healthcare. So the first 3, Title VI, Executive Order, and Section 1557, are broad mandates that you cannot discriminate on the basis of national origin, including language and limited English proficiency, Section 1557 being specific to healthcare. All of those don't go away just because we're in a public health emergency. Then, as the COVID-19 pandemic continued and reached our shores and developed, what we saw was that federal agencies issued their own reminders of these protections. Both FEMA, the Federal Office of Emergency Management, issued their own civil rights bulletin, as well as the US Department of Health and Human Services Office for Civil Rights. Both of them include express language that, whether it's about testing, about access to hospital beds, about all the different pieces, vaccines, now that we're in the vaccine rollout, people cannot be discriminated against on the basis of their language ability. And of course, depending on which state you are in, there may or may not be applicable state law as well. So I say all of that to remind everyone that there is a really robust legal landscape that protects the rights of limited English proficient individuals. And you'll see as we go into the vaccine rollout that some of that comes into question. So next slide. So what are some challenges to equitable distribution overall? And I put up this master list that includes language, but I think it's hard to disentangle, just as you saw in Dr. Cruz's stories. It's hard to disentangle all the different pieces from each other because older adults are both potentially limited English proficient and have a hard time getting transportation. Like, those are all experiences that are within one individual. So the first, obviously, is one that's out of our control, and that's scarcity. Although we developed the vaccine in lightning pace speed, Pfizer, Moderna, Johnson & Johnson, and others, we just didn't have enough shots for everyone. And so that really called into question how we were going to prioritize different populations. And I think you'll also see that, especially early on, when you think about January and February, there was a reliance on mass vaccination sites and technology. So for example, in Orange County, it used to be that Orange County, California, that you had to get you had to download an app in order to register for an appointment. And the hotline, it was like, good luck calling the hotline because no one would ever pick up or was always busy. There also were issues of accessible registration and sites. So that here I include language as a specific issue. A lot of public health departments that were running registration and pointing people to appointments did not have and do not have appropriate language access. Unfortunately, what a lot of them have done is in the upper left-hand or upper right-hand corner, there's an icon for Google Translate, and you pick your language and that's it. And that's as much access. And we know that Google Translate is an inadequate substitute for meaningful language access for older adults. And so that has been sort of one of the unfortunate developments as we've rolled out the vaccine rollout, is that there really remains a language access barrier, both with the registration process and also in terms of on-site. We've spoken to individuals, for example, who went to somehow manage to get the appointment, goes to the vaccination site, and because they're limited English proficient, an older adult, they didn't know that they had to sign up for shot number 2. So they actually left shot number 1, not scheduling shot number 2, and it wasn't until a couple of weeks later, by circumstance, by chance, that someone told her, "Oh, well, did you sign up for your second appointment yet?" And then so that's really a common experience as this rolls out. There's also complications with respect to vaccine logistics, and that's really true for both Pfizer and Moderna, as you both know, as everyone knows, is a 2-shot deal. There are certain very specific cold chain storage requirements. It's a pretty fragile vaccine from that regard, and so that really poses a lot of issues with mobilizing the vaccine for different populations. I know a number of you in your registration comments asked about homebound. What's the plan for homebound? How do I get homebound older adults the vaccine? And that has been one of the really hard tension points, is that when you have such a fragile vaccine that has specific cold chain storage requirements, how do you get that to people who cannot get to a vaccination center? And so that, I think, will start to change as we see more and more of the Johnson & Johnson come in, which is, of course, not subject to the same cold chain storage requirements and it's just a 1-shot deal. But it still remains one of the issues in rolling this out to different populations. There's less of an issue now, I think, around vaccine confidence. And now it's really about scarcity. People are just vying for the appointment slots. And then I'll also say one challenge is that some states have really used a strict age-based system, for example, in Connecticut, in terms of the allocation, which makes it hard sometimes, for example, if you're a 50-year-old homeless older adult, you're probably just as much at risk as a 65-year-old housed older adult. And so sometimes the age-based cutoffs don't recognize the different inequities that exist for different populations. Next slide. And so all this leads to what we know to be true, inequitable distribution. And I apologize, there's some noise in the background, there's construction happening near me. But inequitable distribution, all that sets us up for this graph. What we see is that in those jurisdictions, in those communities that are reporting by age and race. So a lot of times we get the age reporting, a lot of times we get the race reporting, but at the intersection of age and race, what we see is, as of last week, when I last updated these slides, still a lag in different communities. So in South Carolina and Washington State, I should say, and Los Angeles, California, the percentage of white older adults who are vaccinated as a function of the total, racial population 65 and up, compared to older adults of color, continues to be higher. That white older adults, the vaccination rates are higher. And as I've updated this slide from week to week when I do this presentation, those bars keep rising, which is a good thing. And the differences between those bars keep rising, but there still remains a lot of work that needs to be done. Next slide. And so finally, I want to close with some recommendations. When you get the slide deck, you'll be able to click on the word recommendations and it'll take you to a blog post that we wrote at Justice and Aging about principles behind equitable vaccine distribution for older adults. And I think it's really important, right now there's a scramble. President Biden has said that basically everyone who wants a vaccine should be able to register in a matter of a couple of weeks. But it's important to remember that there are some older adults who were prioritized earlier who still haven't gotten their vaccine. So how do we wrap up the older adult population in an equitable manner? Well, our first recommendation is that to create as many channels and sites for vaccination as possible. That includes the homebound, that includes different places where people might go and are used to going, using those trusted messengers, for example, senior centers and others. There have been some really great local partnerships that have been established. And I'll also say that, to this point, President Biden just yesterday announced an additional $100 million to the Aging and Disability Network to help build that infrastructure, to continue to build the infrastructure. Ensure that there are multiple ways to register. I think the Orange County example is a really good one. An over-reliance on technology is not going to get older adults to the vaccination sites and get the shots in their arms. And then partnering with and compensating community-based organizations in a targeted manner. And so, on the previous slide, I showed you all the different disparities in certain communities. It's really important that we're using the data, to the extent that we have the data, to leverage specific partnerships with community-based organizations to make sure that we're filling those gaps. The process, of course, has to be accessible. That includes the transportation, that includes the logistics, that includes the homebound piece. It also includes language. As I said before, there's a number of federal requirements that ensure language access. And then finally, I think this is a moment where we should focus on cross-movement coalition building. By prioritizing those who are most at risk, and we see the data shows that it's clearly older adults of color who are most at risk in this global pandemic, that we're prioritizing all the older adults in all of our communities. That when you prioritize the 70-year-old older adult who's a farm worker, you're prioritizing farm workers who are higher risk. And so this, I think, in a moment of scarcity, when it's so intrinsic to think about your own population, your own community, that this is really about protecting and making sure those who are most at risk get the vaccines first. There will be enough, there will be more than enough for everyone later down the road. But to be caught up in sort of different turf wars about who gets the vaccine first and who should get it second, that's sort of losing sight on really the overall, I think, societal aim is to make sure that everyone who is most at risk gets prioritized first. And then, we can sort of figure out the allocation afterwards as we've prioritized those people who are most at risk. So again, I encourage you to, and I recommend that you visit our blog post when you get these slides, and you'll see more of our recommendations in greater detail. And with that, I'm going to turn it back to Lauren, and I look forward to your questions and the Q&A at the end too. Thank you.
Okay, Denny, we do have time for just 2 quick questions, and then we can have some other questions when we get to the Q&A. One of the questions is, can you give us the reason or reasons why more minority communities are being hospitalized at a higher rate?
It's like we have time for 2 quick questions. Let me pose a really, really big question. I will try to make this succinct, and it is not a complete answer. As I was sort of hinting at before, COVID-19 is shining a really bright light on problems in the system long before COVID-19 reached the United States of America. If we take the issue of medical racism, for example, people having regular access to a doctor, people's doctors believing them when they're talking about their conditions and how they're experiencing their healthcare. All of that is caught up in the current system. And all of that, I will say, quite frankly, works against older adults of color. And especially for older adults of color, they've lived with a systematic lifetime of racism, where that racism compounds and it just builds up over and over as people continue to age. So I think a simple but incomplete answer is that medical racism and disparities, social determinants of health, all of that is at work even before COVID-19 got here. And I think what COVID-19 showed, especially in a global health pandemic or emergency, is that those systems continue to fail the people who quite honestly were deliberately shut out from being prioritized and being acknowledged, again, even before COVID-19 got here. So I think, systemic racism is a big piece. to why we see the higher rates of hospitalization. And so we can talk more about that, but I think that's probably a simple answer given the time that we have.
Thanks. Okay, one more quick one. Does this broad prohibition against language discrimination apply to illiteracy?
And so it'd be interesting to hear what the person has in mind in terms of illiteracy. The language access protections that I highlighted on the previous slide and all the different federal authorities are really about when someone doesn't speak English fluently and they speak another language, whether they're a monolingual other language speaker, or if they are or if they're limited English proficient, like they speak some English but don't speak 100% fluency. So that's the realm of the recommendations. If someone is unable to read and write any language, that is an interesting hypothetical, but it certainly would protect instances where a person doesn't speak English and doesn't read or write English. If that's how the person's thinking about illiteracy, that would certainly be a protected characteristic that the federal authorities I outlined earlier would cover.
Fantastic. Thank you so much again. So we are going to table some of these other questions that have come through for our Q&A later on. And we are going to go ahead and move to another poll question that we have for you. Do you have enough translated information to understand the vaccine? Yes, no, this question doesn't apply to me. Or if you don't mind typing your response in the chat, that would be great. And we'll leave this open just for a few more seconds so we can get as many responses as possible before we go on to our next speaker. So I am going to go ahead and close the poll, and it looks like a lot of you say the question doesn't apply to you. Okay. Well, thank you very much for responding, and I'm going to go ahead and turn it back over to Lauren.
Thank you, Jennifer. It's my pleasure to introduce our next speaker, and thank you, Denny. Sorry, before I move on, thank you so much, Denny, for giving us, that really updated information around who's getting the vaccine and what the barriers are. And I think we saw a lot of questions popping up in the chat that I'll look forward to hearing more about in the Q&A at the end. Next up is my pleasure to introduce Dr. Pamela Monahan-Giernart, who is an assistant professor at Northern State University in South Dakota. Her research focuses on culturally responsive delivery of healthcare and caregiving for Indigenous elders. Before I have her come back on, we're just going to do one more quick poll question and then she'll get started.
So we are asking, do you reside in a rural or urban area? We've got urban, rural, and suburban, if you don't mind responding. And again, we'll just leave this open just for a few seconds while we get your tallies. Thank you so much. And it looks like we've almost got an even split between urban and suburban. All right, go ahead, Lauren.
Thank you. I'm just going to re-welcome Dr. Giernart again.
Thank you so much. Hihani Washte, which means it is a good day. I want to thank our sponsors for allowing me to come be here and talk to you about what's happening in our rural and reservation communities. Next slide. So one of the things we often don't think about living in this vast country of the USA is how much of the area really is rural and how much health disparities exist in these rural areas. And I wanted to just spend a couple minutes at first talking about what it looks like in rural America and some of the main issues that happen in rural America and how they were definitely part of the issue with the pandemic and also going to be part of the issue with getting the vaccine to others. And so one of the first things I wanted to talk about is while we seem to be an industrialized nation and we seem to be modernized. That isn't the case everywhere in rural America. And it's also not the case on our reservation communities. So one of the important things we know about social determinants of health and keeping people healthy is access to things like clean running water and adequate sanitation infrastructure. If you remember when the pandemic first hit, that one of the communities that was hit hardest was the Navajo Nation. And part of that was based on one of the first recommendations for when COVID hit was the idea that it was very important to wash your hands. Remember, wash your hands, wash your hands. And that is still a very valid safety measure. However, access to running water is not everywhere. And the Navajo Nation has one of the hardest hit areas for access to running water, not only because it's primarily in a desert, but because of the infrastructure in the area. So their pandemic numbers and their cases rose significantly, just part of basic lack of infrastructure that we see. Another issue we see in rural areas is multi-generational and often overcrowded homes. This happens both in rural communities and in reservation communities. When we look at reservation communities, we often see cultural reasons for the reason why many families live together. Grandparents help look after grandbabies, and cultural transmission of knowledge and values is transmitted from generation to generation. So multi-generational families and multi-generational homes are often a very desirable aspect of growing up and not to be seen as a detriment to staying healthy. Finally, one of the third things we see in rural areas is the limited access to medical resources. What I mean by that is that the distance to get to a hospital, to get to a clinic, can be very long. It also requires things like access to vehicles, access to money to put gas in vehicles, etc. These affect all rural areas and reservation communities. Again, if we want to look at one of the things that happened, I'm in South Dakota, and in South Dakota, the Cheyenne River Sioux tribe decided to block access to their reservation to try to keep traffic out, freeway traffic out, because they knew that the influx of outsiders coming in, any traffic coming in, people that could possibly transmitting the virus coming in, could cause problems. The nearest access to any kind of large medical facility is hundreds of miles away. And even that very large medical facility still only had about 3 to 5 ventilators. So one of the things we see in reservation communities is this self-preservation to try to work within the boundaries of what they have to make it safest to keep their community members not exposed to the vaccine or not exposed to the illness, and to be able to preserve their areas. Next slide, please. This is going to reiterate some of the comments that Denny had talked about earlier. But the importance of the vaccine for Native Americans is pretty profound. Denny's slide mentioned, if you took a look at it, that American Indians were probably the hardest hit in terms of hospitalization for the COVID-19. This again, and I think he answered this nicely in his Q&A about the idea that historical disparities, historical racism, and I want to add in one more component, that poverty are key components to having poor health, right? Higher rates of diabetes, higher rates of obesity, all of these things, all of these social determinants of health are not personal lifestyle choices, but actually socioeconomic choices, socioeconomic conditions that lead to it. Native folk are about 3.5 times more likely to contract the coronavirus. They're nearly 2 times more likely to die from the coronavirus. And those that die are often younger. And again, these social determinants of health are really important for us to see these pre-existing conditions that arise from a lifetime of structural racism, that arise from a lifetime of inequality and poverty, are important to consider. Next slide, please. When it comes to vaccines, though, our tribes have been able to have a really great rollout in a lot of ways. Tribal communities, and these are federally recognized Indian tribes. I don't want to get into non-federally recognized. That's a whole other presentation. So access to vaccines comes from 4 different places. It comes from Indian Health Services, it comes from tribal health departments, it comes from state departments of public health, and it comes from urban Indian health centers. So the number of ways that vaccines can get out to the communities is diverse, and that's really important. Well, I'm going to be talking today about our reservation Native folk. 70% of most Native Americans live in urban settings, and so we're only talking about a smaller percentage of those that are on reservation communities and that fit into these rural areas. So there's a 4-pronged approach, or 4 different ways that Native folk, tribally enrolled Native folk, for the most part, can access vaccinations, which has really helped get vaccines out to Indian communities. Next slide, please. One of the ways that this is happening is each tribe, now federally recognized tribes are sovereign nations. That's an important thing to remember. As a sovereign nation, tribal governments can distribute the vaccine any way they see fit. And they have been able to do that, and they have been able to create their own priorities. One of the interesting things that many tribes have done is take a look at what priorities they need to have, and elders are always a priority in Native communities. But they've also done an interesting thing in that many tribes have prioritized Native speakers. And while today we'll hear about accessing services in different languages, one of the things we need to understand is in Native communities, their languages are dying, and there's not as many tribal speakers as possible, or as it has been in the past. And so the ability to preserve the culture and the language is essential. And tribal governments have realized this and have prioritized Native speakers to get vaccinated. Now, Native speakers are not necessarily the elders. Due to systematic racism in boarding school, many of the elders do no longer speak their native language. So often the Native speakers that have been chosen to be vaccinated might actually be slightly younger. We also see that tribal governments understand this nature of multi-generational households and multi-generational families. And so when they opened up vaccination, while it was important to serve the elders and get them vaccinated, they also realized that elders rarely live in isolation, and elders often live with any multi-generational family. And so it seemed inadequate just to vaccinate the elder when the elder has got their children, their grandchildren, and their great-grandchildren all in the home. And so in that way, they've managed to take vaccination in a much more holistic and a much more family approach, and kind of looking at understanding how families exist in Native communities and what a vaccination plan should look like in these areas. Next slide, please. In looking at how communities are organized, or looking at how families are organized, we also need to pull our lens out a little bit and look at the idea of communities. Through federal policies in the late 1800s, specifically the Dawes Act, we see that the Dawes Act tried to create not only reservations, but also to create this kind of patchwork of tribal and non-tribal land, parceling out land in acreages for farming, and land that was not purchased or given to Native families were given to non-Native families. And so many a times in rural areas and in reservation communities, we see this kind of literally checkerboard of tribal families, tribal communities, and white families and white communities. And because of that, we need to think about that people don't live in a bubble. People don't live in a community where everybody is exactly like them. And we may need to get services in the next community over. And so what many tribes did is they got access to the vaccine was to start inoculating other community members in border towns. So while the vaccines were given through Indian Health Services, once we got our elders vaccinated, our language speakers vaccinated, we looked at moving that vaccine to other people in the community and seeing how that works. And so this idea of sharing the vaccine with non-natives in the area is a way to sort of create that herd immunity and to understand we don't live in silos, we don't live in isolation, and that to preserve communities and to preserve our native communities, we also need to be looking at who else we interact with. Next slide. I wanted to just take a moment to talk about Alaska. Alaska is a special challenge and a very important special challenge. So Alaska is home to 229 of the 574 federally recognized tribes. So while Alaska is big, it also has 229 sovereign nations within it. Sovereign nations that are very difficult to access, sovereign nations that are rarely on full road systems, sovereign nations that require planes, snowmobiles, dog sleds, that have incredibly cold temperatures. And what we've seen is Alaska has done an amazing job. And Alaska has done an amazing job at vaccinations because Alaska is used to this. Alaska is used to having to go above and beyond for health services. Alaska should be seen as the role model for almost every rural area in terms of how to quickly get people out, how to find people, how to get to homes, etc. And they have been doing a phenomenal job. If Alaska is the 5th highest state, or at least it was last week when I checked, in terms of vaccination rates. So if you think about how large Alaska is, and you think about how there are very few big cities in Alaska, Fairbanks and Anchorage, the travel to the small communities to vaccinate 35, 75, 250 people at a time, and then to fly out and head over to the next village to vaccinate, roll out again. The good thing about this is when they get to the villages, they will do home visits. They will drive around and get everyone taken out. Or in this case, as you see in the photos, they use a lot of dog sled. They aren't really having a problem with temperatures, as Denny mentioned earlier about keeping both Moderna and Pfizer vaccinations cold. That is one of the advantages of Alaska and traveling. But they're really making a great effort in doing that. And they have an amazing public health and Indian Health Services program established so that they can take these vaccinations to these communities and get vaccines into the arms of the entire community in one shot. And this is where they're going to ignore the idea of we're just going to vaccinate people over 65, or we're just going to vaccinate, right? They're going to come into that village and they're going to hit everybody because it's not cost effective, it's not time effective to go through and come back multiple times by multiple age groups. So entire villages get vaccinated at a time. Last slide, please. So one of the things I wanted to end with is this idea of why vaccinations are working so well in Indian country. And well, we often see skepticism by minority populations towards vaccines, and I think that is justifiably so, given how many minorities have been mistreated with vaccinations or with medical treatment and medical racism, and certainly with smallpox blankets, et cetera, that have been handed to our native folk. There should be sort of a fear of vaccination, but I think these 3 principles that I've posted up here will really kind of explain how the vaccination has been working. And so the concept of 7 generations and of being able to pass things down to the 7th generation and have that 7th generation be advocates is really important. And so vaccination to encourage the 7th generation to keep the generations going has been important, as well as the second point, the act of honoring ancestors, who one of the big things in Indian community is we are still here. The fact that the Indian population was not completely wiped out through genocide carries a strong meaning to keeping the next generations alive as well. And again, the idea to go on to fight to protect Mother Earth has been really important in our native communities to encourage vaccination and to keep tribes healthy. Thank you so much. I'm not sure I saw any questions pop up, but let me know if there are.
Oh, thank you so much, Dr. G. That was very, very awesome. We actually have accolades for you as well in the chat, and they're saying thank you so much for the helpful paradigm to help teams visualize. So that's great. We really appreciate that. We are going to go ahead and go on. We're going to skip this poll and go ahead to Lauren.
Thank you. And thank you, Dr. Giernard. That was really helpful. I especially love the visual and the example of how Alaska is being more respondent to what makes sense for their community. And I think we're always looking for best practice examples of what is working to really get folks vaccinated in common sense, best practice ways. So thank you so much for sharing that. Next, it's my pleasure to introduce Frances Hune, who is the National Project Coordinator with the National Asian Pacific Center on Aging, or NAPCA, who is another member of the Diverse Elders Coalition. NAPCA is a nonprofit organization focused on promoting the well-being and quality of life of Asian American Pacific Islanders as they age. In her role, she helps lead projects centering on ensuring API, older adults and family caregivers are represented in research and have access to in-language quality resources. So welcome, Frances.
Thank you, Lauren. Hi, everyone. So today I'll be building off of the previous presentations and talking specifically about the barriers to vaccine access for Asian American Pacific Islanders, AAPIs. But first, I wanted to recognize that I'll be providing quite an aggregated overview of our AAPI communities. I hope that this presentation will then encourage folks to go out and learn more about each specific ethnic AAPI community and their needs. Next slide. So like Lauren mentioned, NAPCA is a national nonprofit organization. Our mission really is to envision a society in which all AAPI older adults and caregivers age with dignity and well-being. Next slide. So this slide just provides an overview of how diverse our Asian American Pacific Islander communities are. AAPIs represent more than 40 unique cultural and racial identities originating from the Asian continent or the Pacific Islanders. Across the US, AAPI older adults, 55 years and older, make up about 4% of the total US elderly population, and they also make about 20% of the total AAPI population. AAPIs also represent over 100 spoken languages, and about 56% of our Asian elders are considered limited English proficient, so LEP. Next slide. So today I wanted to highlight a major project that NAPCA has been working on with the University of California, San Francisco, UCSF. So this project is called COMPASS. It's quite a long acronym, but basically COMPASS is a nationwide survey about the COVID-19 mental and physical health effects on AAPIs. So that we hope that the COMPASS findings can help inform future policies, programs, and additional research that can then alleviate the adverse effects of COVID-19 for AAPI communities. The survey was able to collect over 5,000 responses from AAPI adults all across the country from October 24th to January 26th of this year. This COMPASS survey was administered online, by phone, or in person, and it was available in multiple languages, including English, Korean, Mandarin, Cantonese, and Vietnamese. Next slide. So today I wanted to provide a brief overview of the responses that we received from this COMPASS survey. The cultural groups that participated in the survey included a number of ethnic AAPI communities. Majority of folks included those from the Chinese, Korean, and Vietnamese community, but we also had community members from the Asian Indian community, Taiwanese, Japanese, Filipino, and Native Hawaiians or Pacific Islanders. The mean age of respondents for the COMPASS survey was around 45, 46 years old. But 42.5% of our participants were considered older adults, so 50 years and older. As you can see on the right-hand side on that map, we had quite a number of folks all across the country participate in the survey. A majority of folks, 64.8%, came from the West Coast, but we also had folks from the Midwest, so 8.7%, folks in the South, 14.3%, and folks in the Northeast, 12.2%. A majority of the folks that completed the Compass survey were considered immigrants, so 65% were born out of the US. Next slide. And so now getting into some of the findings from this Compass survey, we had 3 in 5 participants of the survey report that they experienced discrimination in the past 6 months. I wanted to highlight these discrimination findings because I feel like they provide a good context for just how folks have been navigating the COVID-19 pandemic and the rise in xenophobia and anti-Asian racism. So the percentage of folks who strongly or somewhat agreed with beliefs concerning how the COVID-19 pandemic affecting AAPIs are listed in this slide. So 59% believe that the country has become more dangerous for their specific ethnic group. And 34.1% worry about people thinking that they have COVID-19 because of their race or ethnicity. And also 15.3% believe that people of their race or ethnicity will not receive as good COVID-19 healthcare as others. And while that last point is quite a small percentage, it still highlights the number of fears and perspectives that folks have within the AAPI community when it comes to access to healthcare and quality healthcare at that. Next slide. So now I wanted to share some key vaccine willingness and concern findings. So the chart on the left shows the proportion of participants willing to receive COVID-19 vaccination by age group. And the dark blue shows the percentage of folks who responded as definitely or probably yes to receiving the vaccine. And while majority of the age groups show that they definitely or probably yes want to receive the vaccine, we still have quite a number of folks who shared that they are unsure or unwilling to receive the vaccine. 25.4% said that they were unsure or probably or definitely no to getting the COVID-19 vaccine. And amongst this group, 24.8% were Asian Americans and 48.4% were Native Hawaiian or Pacific Islander. 76% reported having one or more concerns about the vaccine, and they shared that the most common concern was the side effects. So 65% of folks who participated mentioned that side effects were their largest concern. This speaks to the need for greater outreach and health literacy in our AAPI communities. Next slide. So how can we make COVID-19 vaccines more accessible and equitable for our diverse AAPI communities, especially those who experience greater health disparities and inequity? Next slide. So I wanted to share this data point with everyone. So AAPI families have a higher percentage of multi-generational homes and caregivers. 42% of AAPIs are caregivers compared to 22% of the general US population. Next slide. So in King County, Washington, initially for the vaccine rollout, Phase 1A focused on older adults in long-term care facilities, but this failed to consider the many dependent older adults receiving family care at home and the number of multi-generational homes that exist in AAPI communities. So in response to this, a coalition of over 200 individuals and organizations, including NAPCA, representing different communities of color all across the state of Washington, specifically in King County, advocated for the state to vaccinate older adults and their caregivers, including those that live and receive care outside of long-term care facilities. Next slide. Because of this advocacy, the state announced in January, so January 6th, that it would then expand eligibility to include caregivers and care recipients who are 50 and older and living in multi-generational homes. Through this advocacy, the state was able to lower the age restrictions and allow for more older adults who receive family care to gain access to the vaccines. Next slide. However, while these efforts were good, who was still left out? Are younger caregivers. So those who were younger than 50 years, who cared for older adults at home in these multi-generational homes were not eligible in this expanded eligibility for phase 1B1. Because of their age, many of these caregivers were not eligible for the vaccine in the first tier, and shared that they would actually have to wait maybe up to a year to finally receive the vaccine. While through these advocacy efforts, we were able to advocate for our older adult caregivers and care recipients, there's still a lot of work to be done in terms of advocating for AAPI communities and their specific needs. Next slide. So equity in vaccine access requires us to think critically of who makes up our communities. AAPI communities are diverse, like I've mentioned in the previous couple of slides. While this list of what our communities look like is not exhaustive, I wanted to highlight the specific communities or specific qualities of our AAPI communities that make us unique. So our AAPI communities include, like I mentioned, multi-generational households and caregivers. It includes low income, including extremely low income communities and those experiencing poverty. It also includes multilingual community members and those who are proficient in AAPI languages other than English. And it also includes folks who lack access to transportation, so walking communities, and those who have limited access to technology and limited digital literacy. Next slide. So echoing what's already been said by the previous panelists, it's important that from planning to the distribution of vaccines, that we center these different communities and their unique needs. This includes making sure information on COVID-19 and vaccines and health literacy is in language and tailored to these specific communities. It also includes increasing outreach efforts, so working with community-based organizations who have deeper relationships and trust with these different communities. It also includes ensuring the vaccine appointment system is accessible to those who lack digital literacy and technology, and also ensuring that where these vaccine sites are located are actually physically accessible to our communities. A lot of mega sites, speaking specific to Los Angeles, require you to drive up, and this is not accessible to our communities who primarily walk and take public transportation. Government agencies must take the lead of and provide more resources to community-based orgs that know our communities best. Equity and vaccine access ultimately requires us to relationship build and do more advocacy. Next slide. So here are some resources that I wanted to highlight that I hope could be helpful for everyone here in the different communities that you serve. So NAPCA launched a community resource helpline for older adults and caregivers last year. This helpline is available in 8 different languages, so that includes English, Mandarin, Japanese, Vietnamese, Cantonese, Korean, Tagalog, and Spanish. We have counselors who are able to provide in-language support to folks who are looking to access information around COVID-19. Next slide. We've also recently launched this multilingual vaccine site locator on our website. This is available in 10 languages. And through our helpline counselors, folks who call into our helpline are able to receive support in terms of signing up for vaccine appointments. Next slide. And finally, I wanted to share this resource that comes out of the University of California, Los Angeles, so UCLA. And this is a collaboration between their Institute of American Cultures, School of Public Health, and Asian American Studies Center. It's the COVID-19 Multilingual Resource Hub. So through this website, folks are able to access multilingual information around COVID-19 that is sourced from the CDC and local health agencies. Like you can see from the right-hand side, there are a number of languages that folks can access this information in. And many of these languages oftentimes aren't included, or a lot of the information on CDC and local health agency websites aren't translated fully to really ensure that our communities are able to understand what's going on. And this can be accessed through translatecovid.org. And yeah, so this is my presentation for today. Thank you, everyone.
Thank you very much, Francis. That was fantastic. Again, there's a lot of accolades as well in the chat for you. We are going to go ahead and open it up to all the questions. We do have a few here already in the Q&A box. If you have other questions, please go ahead and enter them there. We're going to go ahead and start. And it would be for any one of the panelists to go ahead and respond. Our first question is, what is the experience with getting a nonprofit like a senior center to become a pop-up vaccine site? We are in Brooklyn, New York, but perhaps there are helpful stories. Anyone want to take that?
I can start. I think there have been a lot, like I was saying in my presentation, there have been a lot of really great local partnerships. So I would say if you are interested, I'm in Los Angeles, for example. I know that one of the senior centers out here is doing exactly that. They're hosting a pop-up clinic with the Johnson & Johnson. So it's a one-shot, get it, you're done. And they're doing it the whole week, first week of April. So I think if you're interested, it involves some coordination. I would reach out to your local county Department of Public Health, other public health agencies. The one that the LA Senior Center is working on is organized with one of the, like a large health insurance company. So I think there's a lot of different avenues that it could be organized, but definitely think that it's worth lifting up those solutions, because I think that's the targeting I was talking about, to fill the gaps that we're seeing in the vaccination rates.
Can I just add one thing to that? Agree very much with Danielle on the fact that many community-based and faith-based organizations are working closely with public health to have multi-day or multi-pronged sites. The other things everyone can do are to, if you're having a site, for example, for a week or for several weeks, let all the other community-based organizations in your immediate area know. So if you're a community health center, make sure you plug into the churches that feed the area. So as much as we can do to facilitate trusted messenger communication broadly, such that people are hearing it from the faith-based organization they trust, the politician that they know in their community, leverage all those trusted messengers to get as many people signed up and in line as we can, and hearing it in the right language from the right people that they trust so that they sign up and show up.
Fantastic, thank you. So we have another question, is how much of refusal to vaccinate is based on historical racial abuse against minorities?
I'll start. I saw this one in the chat and I got excited that someone was asking this. So, it is very difficult to disentangle racism from the history of this country, first and foremost. So that is informing our current everyday structures now. But I think that the instinct that people have, for example, among Black older adults, that, oh, well, they naturally are hesitant because of things like Tuskegee, is actually not the complete story. So there was a really great article that was republished in the Kaiser Health News that they actually interviewed older adults, Black older adults, and asked them, what are your perceptions of the vaccine? What's going on? How are you thinking about it? Is it at all? Are you thinking about Tuskegee? And what people by and large are talking about is racism they've experienced in their lives. And that's the starting point, right? Or the racism that people have experienced in their own families as the starting point. There might be some sort of connection, and they might be thinking about Tuskegee theoretically and sort of these other issues of that are more historical. But I think it's important to remember that the lived experiences that people have, their everyday dealings with the medical system, with their own doctors, that informs a lot about how people feel about the healthcare system, even if you don't get to the historical piece.
I'll just add that I hope that we won't use this, what Denny said very clearly, the history of racism in the healthcare system, to perpetuate said history in there. So it's most important for us to focus on the fact that not talking, as the press has been doing, unfortunately, about hesitancy as the reason, but actually focusing on the fact that people have now had their questions answered or want their questions answered and actually are seeking information in a positive way and actually would like to get vaccinated. So that actually means we have to move beyond that view of hesitancy towards the legitimate questions people have and solving their access issues. So I don't want people to use hesitancy as an excuse to not fix the access problems for those who are standing in line. I think that's been the whole crux of this entire conversation today. There's a lot of pent up demand, and it's really important to now move from questioning to access.
And I think I want to chime in to continue on what Phyllis said. It's also that culturally responsiveness to it. So let's not use the past, but let's ensure or try to work with training our providers or having our communities have a say in how our providers deliver the care, where they deliver the care, what kind of language they deliver the care in, how they treat the people that they're giving the vaccines to. So I think that cultural responsiveness needs to be highlighted, and where we can do it better, where we can highlight where that responsiveness is coming in, whether it be language or ceremony around it, etc. So I think that's a great next step.
Fantastic, thank you. And Dr. G, we have one for you. Do you have any recommendations for working with Native community who are not affiliated with a travel system that has resources? For example, I have a Native partner in Tacoma, Washington, who are not affiliated with the Paiute tribe, so resources and access is limited.
I guess in this case, one of the things, if they're not tribally enrolled, but they tribally identify, I think right now they could probably reach out to that tribe and ask about access. Because like I said, a lot of them are having extra vaccines and are working on the community. So, one of the main issues we have in Indian country is this certificate of Indian blood and proving that you're Indian to get services. And that becomes problematic for a number of ways, but I think tribes have been very generous in their vaccinations. So if they're self-identified, I would tell them to go reach out to that tribe and talk to them to get about getting vaccinated.
Thank you. So we have another one that's a comment and a question. We have concerns about some of the new federal funding, as it states it can only be used for vaccinations in physical spaces that have not previously held vaccination clinics of any kind. In smaller rural communities, this often rules out senior centers, local health clinics, and other congregate settings. This creates one additional hurdle when it comes to making vaccinations accessible and takes more time in collaborating with community partners, and time is really critical in these efforts. We find this new caveat frustrating. Any sort of advice that can be given?
I think this might be in reference to the money that President Biden announced yesterday. what I would say is that was additional money to fund efforts to vaccinate individuals. I don't know the details behind that, but that, a lot of those local partnerships that we're talking about before were being propped up even prior. So what I would say is, if it's true that that funding is restricted to new places, which I understand the logic behind, but that can also be limiting, that it shouldn't stop you from, raising your hand with the public health department, et cetera, to be able to get those partnerships formed.
Fantastic. Are there any good examples of communities getting the vaccine to homebound elders? New York City has a program, but the process or how it's going is not transparent and requires registration by an online form or a telephone call to the central vaccine center as opposed to neighborhood based, and then a wait for screening callback.
I promise I'll stop talking at some point. So I was keeping track at some point, and now there are so many that I've lost track, but certain areas I remember doing, at least getting some press coverage that they were doing these efforts were in Texas, in Chicago, Contra Costa, California, had programs. I recently learned about another program in Massachusetts for the homebound, but that specific issue around how you sign up and whether it's an opt-in or whether you somehow are identified, I don't know I don't know the details on those programs, but those are areas in the country that have been highlighted in the press in the past couple of weeks as launching pilot programs to reach homebound older adults. I think one of the challenges is that from the inception, the vaccine rollout was a decentralized process. And so you don't have a 1-800 number that someone can call to say, I am homebound and need a vaccine across the country. We don't have that as a standard common thing because it has really been left to local jurisdictions to kind of iron out these details of the how.
I think too, I'm going to chime in a little. In our reservation communities, like I said, in Alaska, they're okay going in and vaccinating entire communities and doing some homebound. And I think that's been able to help. But I think one of the other things that we spoke about earlier today was that that our communities of color are working together to get those homebound elders, if we can, transportation to sites, and that these kind of grassroots, while some homebound elders are truly homebound, some of them may be able to be transported, and we're seeing great efforts taken by small communities, by small organizations, by churches, by neighbors, et cetera, to get elders to get those vaccinations.
Fantastic, thank you. We've got one more question and then we're going to have to wrap up. Can you speak to the barriers that immigrant communities who may not have access to identification documents to register or access the vaccine? What are some initiatives to address this issue?
I'll start, but others should feel free to chime in on this. I think it's a real understandable concern and issue is not vaccine competence, but trust in immigrant communities in public health / government generally. And it's completely understandable given the constant attacks in the previous administration for the past 4 years and much broader that are towing a pretty stiff anti-immigrant line. So I know the Biden administration has made really, and the CDC, I think since the inception, made really clear that they would not be sharing information that they're collecting for purposes of vaccination with other federal agencies and other government officials. But it's one thing to say that, it's another thing to really get people to trust you. after you've said that. So I think it's an area that remains a challenge. But I will say that you don't have to have, for example, you don't have to have insurance to get vaccinated. But it's an ongoing issue, unfortunately.
So this is Yanira. I think it's a very important point and a huge issue for many of our communities. And I think that's for the reasons Denny has already outlined. I think that is why it's so critical for local governments and state agencies to work with community-based organizations and community-based clinics and just leaders who are trusted in the community so that they can help engage and bring them close to the process of getting vaccinated. We are helping people register for the vaccines, and I can tell you through our helpline, we are not, of course, asking for immigration status, and we reassure people on the phone that is not a requirement. That's helping a lot, and we're talking about it. But I think we need to talk more about it so that there's a greater comfort level among community members who are heavily represented in the immigrant community.
Fantastic. Thank you all so much. I'm going to go ahead and transition over to Lauren, who's going to wrap us up for the day.
Thank you. So we're a little bit over time. Thanks for sticking with us all. I saw a lot of questions asking for these really helpful slides, and we will be sending those out along with a recording of the video through the Diverse Elders listserv, and we'll be sharing them also with the National Hispanic Council on Aging and Justice in Aging, our co-sponsors, to help promote them through their websites as well. Thank you so much for everyone who attended the webinar. A special thank you to our panelists and speakers, and of course to BioTechnology Innovations Organization. We really appreciate your attendance and also for filling out the polls that'll help us learn about what we will cover in our next webinar on this topic. So have a great day, everyone. And if you want to follow us to learn more about the next upcoming event, you can follow us at diverseelders.org, and we're on Facebook and Twitter and LinkedIn as well. Thank you very much. I think Jennifer's collecting the last of the information, but have a great day, everyone.